Welcome to Morning Commute, expanding the use of oral maintenance therapy for acute myeloid leukemia among community-based clinicians. In this episode, Individualizing Care Plans for Patients with AML, Dr. Amer Zeidan and Dr. Guillermo Garcia-Manero discuss how to incorporate evidence-based treatment plans for patients with AML who are receiving oral HMA maintenance therapy. Who are the best candidates for these therapies? Morning Commute is developed by Projects and Knowledge powered by Kaplan and is part of a continuing medical education series. This independent CME-CE activity is supported by an educational grant from Bristol Myers Squibb. Information about the faculty and disclosures can be found by visiting the URL in the episode notes or by visiting podcast.atpointofcare.com. You can use this link to receive your credit and evaluate this program. Dr. Zeidan is an associate professor of internal medicine, the medical director of hematology early therapeutics research, as well as the leader of the myeloid malignancies clinical research team and director of the hematology division at Yale Cancer Center, Yale University School of Medicine in New Haven, Connecticut. Dr. Garcia-Manero is a professor in the Department of Leukemia and director of the MDS AML Moonshot program at the University of Texas MD Anderson Cancer Center in Houston. I am your host, Candace Hoffman. Dr. Zeidan will begin our discussion.
Welcome, everybody, to this second broadcast focusing on maintenance therapy for management of patients with acute myeloid leukemia. I'm joined here by my colleague and friend, Dr. Guillermo Garcia-Manero from the MD Anderson, and my name is Amer Zeidan from Yale University. Guillermo, good to see you again. And as we continue our discussion of maintenance therapy, we want to try to discuss some of the key data that we touched on in the first broadcast, but go in it in a little bit more detail and then try to understand the patient characteristics of patients who should be considered for maintenance and how do we manage them in the clinic in a day-by-day basis in terms of management of adverse events and monitoring, etc. So maybe you can get us started by going over the history of those oral hypomethylating agents.
Thank you, Amer. It's really, as you said, a pleasure to work with you. Not only you're like a leader, but you're also a great friend. So I really enjoy doing this. So I think the audience is familiar with these hypomethylating agents, azacitidine and decitabine. The story actually goes back many, many years. And in the early 2000s, they were studied in myelodysplastic syndrome. And indeed, azacitidine was approved in 2004 for patients with myelodysplastic syndrome and eventually became the standard of care all over the world for these patients. And later on, we'll also got actually an approval for acute myelogenous leukemia in older patients. The issue with this drug is, it was the first drug to show improvement in survival in patients with MDS. At the beginning, when we were developing this, around that time, there was a question of should we do induction therapy or not in these patients with MDS, but they became the standard of care. But very quickly, we realized that these drugs needed to be given on a chronic basis, meaning you couldn't just do a few months of azacitidine and then stop the therapy in a patient remission because somehow patients eventually will relapse. So we became aware that an oral approach was really needed to facilitate chronic administration of these compounds. First, we actually were thinking about patients with myelodysplastic syndrome. And we developed actually here at MD Anderson, this was one of my first clinical trials many years ago, a phase 0 trial of this compound, in those days called CC486 actually, oral azacitidine. We knew that this drug, this type of hypomethylating agents, nucleoside analogs, are degraded by an enzyme known as cytidine deaminase. This enzyme actually is present in the GI tract, in the liver. So basically, we were expecting that if you were just ingesting the IV or subcutaneous formulation of azacitidine, it's going to be degraded and very little, if any, absorption. But in our phase 0 trial, actually, to our surprise, we saw detectable levels of this compound. And that made us move very quickly into a phase 1 trial that was published actually in 2011 in JCO. That study actually was a very interesting study to be part of. What we did in that trial was on the first cycle of therapy, we will give the subcutaneous azacitidine at the standard dose, 75 milligrams per meter squared daily for 7 days. And then on the second cycle, we'll give it oral initially for 7 days. And there, what we wanted to do was basically to compare the pharmacological profile and the pharmacodynamic profile of the subcutaneous versus the oral form of the drug. This was actually a lot of fun to do because we were getting this PK/PD data on these patients. And basically what we saw is that the absorption was, of course, resulted in a lower area under the curve for exposure compared to the subcutaneous azacitidine. So the curves actually were very different, with the oral azacitidine at a dose of, let's say, 480 milligrams on day 1 being around 13% or so of what you will expect from, maybe the subcutaneous. So it was low. But what we saw on that trial, that was again published in the Journal of Clinical Oncology in 2011, is that despite the fact that this exposure was lower than you saw with the subcutaneous or the IV formulation of the azacitidine, this actually was very active. So we were able to document in patients with MDS complete kind of overall response of around 30%, 50% in few patients with CMML. So basically, after a few cycles of this therapy, we saw clinical activity in MDS, CMML, and AML. And we realized that then we had an oral compound that was active for these patients. Also, because of the PD profile, meaning the induction of DNA hypomethylation that kind of followed a little bit what we were seeing with the IV and the subcutaneous, we realized that we could actually design this in a way, or use this drug not only on the 7-day schedule that we have used with the azacitidine for the MDS AML trials, but maybe 14 days, 21 days, maybe once, twice a day, etc. So there was a lot of possibilities in the use of this compound that in those days we were calling CC486, eventually oral azacitidine. And that actually led to the design of a very large international phase 3 trial known as the Quasar AML 001 for patients with acute myelogenous leukemia that I think we're going to be discussing next.
Yeah, so I think this is a very important trial. And thank you so much, Guillermo, for this, I think, excellent historical preview, because, people think of the phase 3 trials and sometimes don't remember all the multi-year efforts that have taken 10 or 15 years sometimes to develop these drugs to come to the clinic. So I think, it's important to remember a couple of things. One is that this drug, what used to be called CC486, is a formulation of azacitidine. However, it's different. It has different PKs and PDs, different pharmacokinetics and pharmacodynamics. Why is that important? Is because some people have been thinking about, I can just use the injectable AZA instead of the oral AZA in the maintenance setting. But this is very important to remember that this is a different drug when it comes to pharmacokinetics and pharmacodynamics, and therefore it should not be substituted. Now, when you think about the trial itself, it was a large international multi-center double-blind study, placebo-controlled. So really very well designed, very well conducted study that took place in almost 23 countries. So a very large international involvement. And the eligibility, I think, is very important because these are patients who are a little bit older, more than 55. And the reason for that is that in many of the countries, patients with intermediate or poor risk cytogenetics, like the patients who were on this trial, would be going to transplant. And this trial did not get patients to get maintenance post-transplant. Again, very important to remember. So the patient has to be ineligible for transplant to be included on this trial. And the patient has to be in remission. So the patient had already received either induction or induction plus consolidation, were in remission, and they have to be randomized within 4 months of achieving the first CR/CRI. And importantly, the patient should start with count recovery, and then they were randomized to receive oral AZA for 14 days. And this is, again, important to remember. You touched on this, and I think the duration of this drug is very important. And This could be related to some of the previous trials, for example, in MDS, where the trial was not successful. The randomized trial was associated with a longer duration of use. So here it's only 14 days, and you get a 14-day break. And of course, the treatment is continuing until progression or unacceptable toxicity. So this is basically continuous treatment. I think one interesting aspect of this trial is that on the bone marrows, which were done routinely during the trial, is the patient has some mild increase in their blast. They were allowed to go to 21 days instead of 14 days, and some of those patients did go back into remission. So I think this again tells you that the impact of this treatment is probably significantly impacted, not only in terms of side effects, but potentially efficacy by how long do you give the drug for. When we start thinking about the clinical results of this trial, I think the most important endpoint from that trial was overall survival. And that result was statistically very significantly different between the two arms. There was a significant prolongation of 25 months compared to 15 months. And Guillermo, like me, you are involved in management of patients with MDS and AML trials, especially older patients. And to see a trial with an improvement in OS of 10 months is highly unusual. I'm interested to kind of see your thoughts, or maybe your impression when you saw the results for the first time.
I was super excited because this has been our goal for so many years, right? Like, you induce these patients, you consolidate them, and then we were just waiting for them to relapse. And, only a minority of these patients really, unfortunately, go through transplant. And now, after many kind of positive, negative studies with these different HMAs, someone designs a true phase 3 well-designed trial with an active compound. And then, you're like really having a major impact on the survival with, as you mentioned earlier, median survival of close to 25 months for those on the oral azacitidine versus 14 months for the others. So this was really important, and I was really elated when I saw this. You mentioned something earlier that is very important, that is, why these prior studies with the IV subcutaneous azacitidine or the decitabine fail. And I mentioned in the first podcast that in those days we didn't really knew the molecular kind of characteristics of those patients. We're kind of blind. But there is also a very important issue that you mentioned earlier, that is the pharmacological profile of this drug. Actually, for people that had been trying to develop these hypomethylating agents for many years, the goal actually has been to do this kind of chronic exposures. Like, actually, if you could give a drug almost every day, probably that would be pretty good. But if you do that with the regular decitabine or the regular azacitidine, even if they are low doses, that will be associated with very significant cytotoxicity. So it cannot really be done. And I think here, this oral azacitidine, by the virtue of this different kind of lower PK profile and with very potent actual induction of hypomethylation induction, allow us to safely give this 14 days, and as you mentioned, if needed, 21 days of therapy, that I think results in this kind of survival data. So this is really important, and I think has been transformative in the field and one of the most important studies in acute myelogenous leukemia.
And I think another way of putting those results is the 1 and 2 year survival rates, which again, both of them were improved with oral AZA compared to placebo, 73% compared to 56% at 1 year, and 51% compared to 37% at 2 years. I think this is a concept that's sometimes easier for patients to understand. What are your thoughts on the subgroup analysis? I think you mentioned this a little bit, Guillermo, about the different, like that the patients are not all created equal, and maybe there's some differential activity in some subgroups.
What we saw on the study actually is that there was no characteristic that was negatively associated with the use of the drug. Actually, most patients benefited from the oral azacitidine. And I want to emphasize a couple of them. For instance, MRD status. Whether the patient was positive or negative, they benefited from this type of approach. Whether they received constellation therapy, yes or no, the same. And very importantly, the cytogenetic risk category, very, very important. So again, this drug for those patients not candidates for stem cell transplantation works basically across the board in majority of them. And the same actually applied for the overall survival and also for the relapse-free survival. So I think this is a drug that has very clear activity in these patients not candidates for transplantation with AML that are in remission, that clearly benefit in terms of their survival from this intervention.
Yeah, and I think when we start thinking about how to apply this data to our patients in the clinic, I think the subgroup analysis that you discussed, Guillermo, makes this relatively easier because, when all the different subgroups benefit, that makes it generally applies to most patients. So I'll actually mention one example of a patient I treated in my clinic with the drug as a way to kind of think about how do you identify patients who benefit from this treatment. So this is a patient who's 73-year-old when I saw her or when I met her, which was around 4 years ago. She presented with acute myeloid leukemia. Although she was 73, she was in reasonable shape, and importantly, she had NPM1 positive mutation. And we discussed the different approaches. We decided to go with intensive chemotherapy because our goal was to go for a cure because she was NPM1 positive, which is favorable risk. She was FLT3 negative, and she wasn't excited about the prospect of transplant. So we decided to go with intensive chemo. We gave her 7+3. But unfortunately, she had a very complicated clinical course with the intensive chemotherapy, where she had significant buttock infection and needed significant wound changes, and she needed to go to rehab for some time. And at that point, we have decided in discussion with the patient that we would not be giving her additional consolidation chemo because of the risk of worsening of the infection. But we were concerned that she was at high risk of relapse because she only got the induction, and she was MRD negative. So at that point, I discussed the possibility of using oral azacitidine with her. We went over the different profile, and she actually went on the drug, which, as we mentioned, is given 2 weeks on, 2 weeks off. And she actually responded very well. She did not have significant myelosuppression, and she was able to recover from rehab, and she was able to go home, and she has been fully functional. I know we'll talk about the side effects in a minute. The main side effect that she had actually was some constipation. So she needed some additional treatment to make sure that she does not have severe constipation. But aside from that, we did not have to modify the drug dose. And she actually remained in remission for almost 3 years with excellent quality of life. So I think this is one example of a patient I have, and I'm not sure, Guillermo, your thoughts about how does the use of the drug kind of applies in the clinic these days.
I think you bring actually a very important. This case actually is really, really important because we've been discussing in these podcasts that this approach was for patients with not candidates for transplantation, with poor risk features, etc. And indeed, is very important, right? For patients older than 75, patients with poor karyotype, probably patients with P53 mutation and so forth. But your case actually is very important, and we see this all the time. So older patient with quote unquote good prognosis, AML, NPM1 mutated, or let's say core binding factor. Okay, these are good prognosis, but if you're older, actually these patients do not tolerate induction consolidation therapy very well. Indeed, actually, in our series at MD Anderson, we saw that this kind of approach is associated with a very high rate of death in CR, in complete remission. And this is actually the worst thing that can happen to, of course, the patient, but also to a leukemia doctor. Like your patient dies in remission. That's really devastating for everybody. So there is a need also for this group of patients that may actually not be able to tolerate any significant amount of consolidation therapy. And remember, those patients with quote-unquote good features, if they are not really consolidated with cytarabine-based approach, they actually have very poor outcomes. That's actually, I think, a really fantastic discussion with that case that you brought with NPM1 mutation. I think the other issue with this drug also is that, an oral approach is significantly easier for our patients. We didn't discuss this in the prior podcast, but I mean, this is basically taking, your medication at home versus having to go 5, 7, or maybe in this case, 14 days to some clinic to do this. So this is actually, in terms of quality of life for the patient, is actually major. These patients are older. I don't know. I think New Haven is nicer than Houston, but driving here, etc. This is a major problem for this group of patients with this disease that don't need to spend so much time in the hospital. I heard Amer, and I would like to know your point, because actually you've done studies on this area, that is adherence of oral therapy. Some people will say, well, this is very nice. Patients, want to stay home, but are they really compliant with the oral therapy? In other words, if they go home, do they really take their therapies? What is your take on this?
Yeah, I think this is a very important area, because there are several reasons why I think people do not adhere to kind of treatments. Some of them are the patients with, like if they have side effects, how do you mitigate those side effects? And I mentioned with this particular drug, the main two groups of side effects relate to the myelosuppression. And there's actually very detailed instructions with oral azacitidine in the label of the drug about when do you hold the drug, how do you delay the cycle, how do you interrupt, reduce the dose. And the second big issue is the GI adverse events. As I mentioned, my particular patient, the main issue was constipation. However, some patients can get nausea, vomiting, diarrhea, etc. So I think giving antiemetics and giving, which some of the antiemetics, by the way, like giving Zofran, will cause also constipation. So it's very important to...
I was going to mention that, Amer, sorry for interrupting that. I think we are so concerned about the diarrhea and the nausea and the vomiting that we give these antiemetics, and the side effect is actually the constipation. And that seems to bother my patients a lot more than the diarrhea. But yeah, that's interesting.
Yeah, I agree. And actually, some patients can develop diverticulitis if you don't manage it quite well, and other significant problems. And I think the detailed instructions basically for going down on the dose, if you have to, is reducing the dose from 300 to 200 for 14 days, and then to 7 days if you have to. I did not have to do that with my patient, because I was able to manage the constipation with agents to help with the bowel movements and instructing her to take more fibers. But the other issue that sometimes I think affect adherence is the ability of the patient to get the drug covered through their insurance, and sometimes they might need help with their copays, etc. And then I think it's important to educate the patient that compliance is very important to ensure that their disease remains under control, and especially as the patients feel better and they don't have any detectable evidence of disease, which defines like being on remission. I think some patients might, drop their guard and start skipping some doses. But my experience with cancer drugs compared to hypertension and diabetes drugs, etc., is that patients generally tend to adhere to them better. So I do think this is something that is important to still meet the patient. I was seeing my patient every month, although she was doing very well. But again, just to educate her, to make sure we are looking at the blood counts, that we are managing any adverse effects that might come across.
Thank you, Amer, for that very detailed explanation. And I really want to thank you and the audience for participating. Thank you very much for this opportunity.
Thank you so much. My pleasure.
Remember to receive your credit and evaluate this program. Please visit the URL in the episode notes, or by visiting podcast.atpointofcare.com. You can find all the episodes in this series and all of our other podcasts on your favorite podcast streaming service, or download our Morning Commute app. Thank you for joining us today.